getting back to why we need to be, especially the urology world, because for the most part, these patients are, we're the ones following them. We've ushered them through therapy. We started, as you so appropriately mentioned, Jay, we started LHRH therapy very, very early. And I think what gets lost on the urologist, because many of these patients are ECOG zeros and ones, they're asymptomatic, especially who are pre-chemotherapy, in the control arm for 302, so the median survival in the control was probably, 31 months, somewhere through there.
Yeah.
I think the audience needs to understand that there's a limited survival benefit here, survival.
I also look at it this way, and in fact, we've presented this idea of a prognostic index model from 302, and it's fairly intuitive. Patients who had more advanced disease, there was a wide range of people going on to 302, ranging from patients with PSAs in the 200 range with elevations of their alkaline phosphatase and 12 bone metastasis to people with PSAs of 10 with 3 bone metastasis, right? And it's fairly intuitive, but if you look at the more advanced patients, their survival was shorter, but the response proportion was lower, the hazard ratio was lower, they were more likely to go on and develop symptoms earlier, and it says there's this broad window of chemotherapy-naive CRPC. And the data seem to continue to come back to say that the earlier intervention, the better. And that if you're waiting for a patient to suffer and have pain or complications, you're waiting too long. Right. So the idea is start them before they get to that risk.
Chuck, what is unique about that is the fact that if you look at the entry criteria for both PREVAIL and Cougar 302, were patients without symptoms or with minimal symptomatic disease, specifically defined as not opioids, right? Yet the NCCN guidelines broadened that, and now you're allowed to actually treat symptomatic patients, for which I would argue that we don't have, I think most of us clinically think it's appropriate to actually use an oral agent in the symptomatic patient, but we don't have true data as to how those patients do over time. And if you look at your nomogram, it's the same features that we have seen with the Halabi nomogram, the same features that we have seen with Andy Armstrong's nomograms, looking at LDH and so forth. The only difference with this nomogram is the BPI score, which is the pain, which is hard to do in the clinic sometimes because we just simply gauge someone, how much pain are you having, and we decide whether or not that is actually enough for us to treat with an oral agent or move them to chemotherapy.
The BPI score for the 302 patients, they had to have a 0 or 1.
Or 1, yeah.
Even those who with minimal pain had a worse outcome than those with 0 pain.
Correct.
One quick question. Both you guys talked about the challenge, the 3-month or the 8-week challenge with the oral therapies, assess at 12 weeks, and then discontinue at 12 weeks. Why not throw in 6 cycles of docetaxel right at that point, a la Chartered or Stampede? Is that being tested?
I have been, so if you go back in history, for instance, when docetaxel got approved in the United States, 2 trials, the SWOG 9916 and the TAX 327, those trials were specifically stating if you have metastatic disease, independent of symptoms or not, you can go on and get chemotherapy, right? So, but if you, and one of the caveats of that data is that when you look at the long-term follow-up that actually Ian Tannock published, 30% of patients who actually have no symptoms whatsoever, who went on to get docetaxel, 30% of those patients were alive 7 years later. So there was a concern that maybe we were waiting too long to treat patients with chemotherapy, and perhaps then asymptomatic patients should actually also get chemotherapy. And at the time, I was a fellow actually in San Francisco. The question that we have is, well, how can I change your quality of life so drastically if there is no data as to what the best timing for chemotherapy? However, I changed over the last 2 to 3 years because of the data with early chemotherapy. It is possible, that if indeed chemotherapy actually can be given earlier to a very selected group of patients, your outcome is likely to do better than if you wait, until someone has a lot of symptoms, because time to progression will be shorter when you start someone at that time. So I think that, in the context of castration-resistant disease, I don't think you really need to wait for having someone who has a lot of symptoms to start chemotherapy. But I would argue that clinically speaking, if you compare an oral agent with chemotherapy, most men in America will get through an oral agent before chemotherapy.
I would say that given the number of available therapies we have, it's never appropriate to wait for symptoms anymore.
Exactly.
And the point that I want to make another point about TAX-327, which was, you sort of alluded to it, which was, if you look at the hazard ratio for survival in the symptomatic group versus the asymptomatic group, in the symptomatic group, the hazard ratio for survival was not significant.
Correct.
Over mitoxantrone. So it's almost, you know, that again points to that being a later event.
Mike, have you found it difficult to get your partners, I mean, you got a big group, to get your partners to get off that mindset of, oh, they have to have symptoms before I even start looking, let
Yes.
alone treating?
I think the last 6 months have made it a lot easier with the data, with the Charter and Stampede trials, to get these patients, you know, with respect to chemotherapy, probably chemotherapy earlier. And now we are absolutely treating these patients earlier. And I think that we're going to talk about other drugs here in a minute, but I mean, all of these drugs need to be used earlier in the spectrum of the disease.
Right, and I think in the following segments, we're going to stress the point that you were exactly making, Chuck, is the concept of treating early vis-a-vis lower PSAs, lower volume of disease. Hopefully those patients should get better, or should do better clinically with an increased survival benefit.
Well, just staying with chemo for just a second, though, one of the problems is we don't really have a great definition of when to start. Do you start it with 4 mets, or or is the entire pelvis being eaten up? Is that actually a single met, or is that an entire system that's affected? And I think we need to define those a little bit easier, because a little bit better, because I think it's very confusing, not just for the medical oncologist, but certainly for the urologist, to know when to get these patients to chemotherapy earlier.
Exactly.
I mean, if you just to interject for a second, if you actually look at the impact of having one bone met with regards to mortality and subsequent skeletal-related events, it's huge. So if you have metastatic disease, you're destined to die from prostate cancer. So I don't think that all concepts of waiting until you have more disease are really reasonable today. If you look at actually the Netherlands data, the European data prior to all the oral agents that we have, 5% of patients who have bone metastasis independent of volume were dead, were actually alive at 5 years, right? So 5% of people still, so 95% of patients die within those 5 years. If you now look at the data in America, goes up at around 28% or so, right? But just imagine, telling a 55-year-old guy, I'm gonna put you on an oral agent, and what is the median survival of that oral agent? 35 months. So as much as we love the oral agents, as excited we are with these oral agents, the median survival of those agents also incorporates subsequent therapy, right? So the reality of it is, and I think there's a misconception out there with patients, that patients say, oh, the next miracle agent is gonna drive my PSA to 0 and I'm almost cured, and the reality of it is no. Even those patients still have a median survival that is limited, and even though, it is a great therapy, it's still you have to incorporate the subsequent therapy into that equation. So I actually have changed how I speak to my patients about that, because I had a patient of mine who actually was very excited about therapy, and then he asked me for the publication, and I gave it to him, and he almost fell. It's like, you're telling me that with this agent, even my PSA is 0 now, my median survival is 35 months, and I say yes.
Well, half of patients
Exactly.
lived over 35
Exactly.
months.
Right.
So there's a wide range of outcomes that patients need to be aware of.
So let's